Hi, I'm Dr. John Lowe, Professor of Psychiatry at the UC Irvine School of Medicine. Thank you for attending Ask the Doctor regarding bipolar disorder for the NAMI conference here in California. So, I really want to thank you for all the questions. They're very interesting, and so I'm doing my best to answer all of them for you. One of the questions came as to how do you diagnose bipolar disorder? Well, bipolar disorder is not diagnosed by a blood test. It's done by having an interview of the patient, as well as, if possible, talking with the patient's family. Why is this? It's because in psychiatry, unfortunately, most diagnoses are not done by blood tests, but by clinical history taking uh, with signs and symptoms. So, what are signs and symptoms? Simply stated, signs are basically things that you observe, and symptoms are things that patients report. So, what are the key issues when it comes to bipolar disorder? Well, in bipolar disorder, one of the things one has to have is what is called mania. Mania, in essence, is a distinct period of abnormal or persistently elevated mood. So basically, what it sounds like is it's different from usual. And how's it unusual? Well, it's unusual because it's elevated. Typically, that means that the person is really happy, sort of abnormally so, as if they're sort of high on a drug, but they're actually not high on a particular drug. Um, they may have other symptoms too, as well, without going into the diagnostic and statistical manual of psychiatry. Details, they include things as what's called inflated self esteem, which means that they have a higher opinion of themselves. Or they may have what's called grandiosity, which means that they might think they're special or have special powers. They may also have decreased need for sleep, which means that they may only sleep 2 hours or 3 hours, yet feel totally energized and able to function the next day. They may be more talkative than usual. For example, they may talk very fast and be hard to interrupt. They may have what's called racing thoughts, where the thoughts go, as they say, a mile a minute and from topic to topic. Uh, they tend to be distractible and have what's called increase in goal activity, which means that they try to do different things, different projects, but really it's not like they get anything accomplished. They are too easily distracted to take care of these things. Oftentimes they're very agitated, and sometimes they also can have excessive involvement in activities that may cause them some painful consequences, such as spending too much money or perhaps engaging in relationships that perhaps end them in trouble in some fashion. I think a great example is I had a patient recently who clearly had bipolar disorder because he would sing about how he was Felix the cat, because his name was Felix, and he would basically draw really intensely with one arm and then with the other arm a sun, and then if you described it incorrectly, the patient yelled at me actually and said, "You got it wrong, doc. You don't understand these things." And so it's pretty striking when somebody has mania. Now, in order to have bipolar disorder, this mood uh, impairment actually has to last at least a week. And also, in particular, it should cause some sort of disturbance in social or occupational function. What that means is that they have trouble interacting with other people or they have trouble functioning at work. And one of the other keys to diagnosing mania, as I said before, is it can't be related to being high under the influence of either medications or some illicit drugs, such as amphetamines or cocaine. It is possible that it could be under the influence of, say, cannabis or some other substances like alcohol, but that's not typical. So, again, that is the definition of mania, and in order to have bipolar disorder, all you have to have is one episode of mania. Now, you may have heard of bipolar disorder being called manic depressive, and so why is that called that? It's because a lot of patients, not all technically, who have bipolar disorder can have an episode of mania, but they also have an episode of depression. Depression is exactly what you think it is. It's that somebody has a period where they really have depressed mood and low energy or loss of interest in things that they enjoy. I had a patient yesterday who told me that she lost interest in gardening. It used to be the thing that really brought her joy. She would clip her plants and spend hours outside, but in her depression, she really couldn't muster the energy to get up during the day. In fact, after having a difficult night trying to get any sleep, which is another sign of depression, either having trouble falling asleep, staying asleep, or even for some people, it's the opposite. They sleep too much, but they don't feel rested. Um, Patients with major depression also have uh, either increased appetite or actually more commonly decreased appetite where they lose a significant amount of weight. Again, not due to having cancer or trying to, just because they've lost the will to eat and desire to eat. Um, Patients with major depression also have what's called either psychomotor agitation or retardation, which means that they look really slowed, or they might look slightly irritable, but not irritable in a mania way, but somebody who is depressed and is feeling not well. They often report fatigue or loss of energy. They may feel worthless or inappropriate. Oftentimes, they just don't have the concentration or energy to focus on tasks at hand. They also have at times recurrent thoughts of death or wanting to kill themselves. So, depression is very common, and what happens is that to be defined as a major depressive disorder, these symptoms have to last about 2 weeks. So, just to recap, major depression has depressed mood, decreased interest, decreased energy, uh, lack lack of desire to eat, or perhaps eating too much, or and with therefore some weight loss or weight gain, but definitely a diminished ability to function. Now, as I said earlier, bipolar disorder can be just an episode of mania, which is the opposite of depression, but it typically has both mania and depression, hence called bipolar, as in the two poles of mood. Now, bipolar 1, you may have heard of, versus bipolar type 2. What are the differences between the two and why does it matter? Well, it used to be thought that bipolar type 2 was basically a less severe form of uh, bipolar disorder, but the reality is not true because what it is that in bipolar type 2, patients basically have what's defined as hypomania, in the sense that they have manic like symptoms, but they're just not as severe. And how is it not severe? Well, they're very much similar in the sense that they can have rapid speech, excessive energy, impulsivity, and things of that nature, but it just doesn't last as long. So, in the difference between mania versus hypomania, mania lasts at least a week. Hypomania cannot last more than 4 days. So, that's really the main distinction. And so, similar to bipolar type 1, patients with bipolar type 2 typically either have a hypomanic episode alone or they have hypomania, but they can also have a major depressive episode as well. And really, when it comes down to it, although I'm jumping a little bit ahead, the treatment of bipolar type 1 versus type 2 is pretty much the same. It's not much different. You may also have heard something called cyclothymia. You think, oh my goodness, what is that? Is that distinctly different? No. Cyclothymia is also a mood disorder. What that means is somebody with cyclothymia typically has a hypomanic episode, and they also have symptoms of depression, but the symptoms of depression really do not meet criteria for a major depressive disorder. Oftentimes, patients with cyclothymia who say that they feel uh, excessive energy and things of that nature, I actually find it very helpful. And one of the key distinctions with cyclothymia or perhaps hypomania is that while it can cause some decrease in function, it really doesn't interfere that much with occupation or interactions with people. It might do a slight amount, but definitely it's not as severe. Another thing you may hear about is that if somebody is so manic that they end up in the hospital, well, then by definition, that implies that it's pretty severe, and therefore, it really isn't type 2, it's pretty much type 1 of bipolar disorder, meaning that the manic episode is quite severe, and that is why patients end up in the hospital. So, we've talked about bipolar type 1, bipolar type 2, and cyclothymia. What are other symptoms in this differential? Well, that also includes possibly people may have ADHD. So, what is ADHD? That is hyperactivity disorder. And typically, to people with ADHD have difficulty focusing. They tend to be hyperactive and they move around a lot. You've kind of seen that. Now, when somebody has ADHD, especially in children, it makes it hard to diagnose bipolar disorder because there is some overlap in the symptoms of ADHD versus bipolar disorder. This is why diagnosing bipolar disorder in children is possible, but it's challenging because what is defined as normal behavior in a child is very different, right? They're still developing, and so it's really not clear what is abnormal for that behavior in terms of excessive. And so to diagnose a child with bipolar disorder is definitely possible, but one has to really observe the child over a period of time and have the symptoms be pretty consistent. One way I guess you could sort of figure it out is that ADHD responds well to stimulants. And so if a, say, adolescent with bipolar disorder had stimulants, well, chances are that stimulant that's used to treat ADHD would set off a manic episode, possibly. And hence, that's one way to figure it out. Not exactly that you would really want that, because frankly, that could be very dangerous in having the child or adolescent go into the hospital. What are other things in the differential? This is what psychiatrists talk about, other diagnoses that could be possible. So sometimes you may see, one of the frustrations, and I understand this, is that your loved one or you see 10 different psychiatrists and you end up with 10 different diagnoses. Why is that? Well, it's because there's lots of what we call symptom overlap. And so one of the common things you might hear about is that somebody has schizophrenia. So how does schizophrenia differ from bipolar disorder? Well, it's really in essence that bipolar disorder is considered a mood disorder, which is a disruption of mood. Schizophrenia is considered a psychotic disorder. And so we have to think about it. What is psychosis? So psychosis basically is characterized by things such as delusions. Delusions are fixed and false beliefs, such as, which sounds like bipolar in a way, like, oh, I'm really special. But they also tend to be, which is not typical of delusions in bipolar disorder, they could be persecutory. Oh, they're after me. They want to hurt me. They also could be referential, which is that, oh, that TV, it's sending messages to me. I know that commercial is saying that the apocalypse is coming, and therefore I'm going to be in great harm. They could also be grandiose too in schizophrenia, which is that I have a lot of money, or I'm the king of Prussia, something like that, because one of the things between schizophrenia and bipolar disorder are that you can't have delusions. But the delusions in schizophrenia tend to be a bit more bizarre and strange, whereas the delusions in bipolar disorder are not usually as stressful and tend to be funny in a sense. Not necessarily, but typically. Also in schizophrenia, the delusions can also have somatic ones, such as that, you feel that there's something in your brain and it's implanted. For example, a chip in your brain that's controlling your behavior. Delusions and schizophrenia also can be religious nature, which is that they might say, I'm the Antichrist, or they might say that, God is punishing me because they told me that I'm going to hell. So, one of the things I forgot to mention is that, and one of the reasons why it may be challenging to diagnose bipolar disorder versus schizophrenia is that one of the things that makes diagnosis of bipolar disorder and schizophrenia somewhat overlapping is that both can actually have these delusions. So, for example, in bipolar disorder, when one has a delusion, as I mentioned earlier, it typically is more kind of grandiose. I have all this power, I have all this money, I'm something special, which can happen also in schizophrenia, but as I mentioned, schizophrenia typically has more persecutory, they're out to hurt me. And also the referential, such as, oh, that message on that billboard, those numbers, they have meaning, they're coming to get me. But one thing about schizophrenia, which is different, is that delusions tend to be present during the entire course of the illness, which means that when the patients get better, they don't really believe these things as much, or they're less bothersome. Whereas in bipolar disorder, delusions are not typical unless someone is severely manic, and therefore they have these sort of grandiose delusions. At the same time, you can also have depression, a really severe depression with what's called psychotic features, which means that you can have delusions in major depression as well. So therefore, the typical one, say, I had a patient that told me who was very depressed, she would say, oh, Dr. Lowe, you're zapping my brain. I was offering her electroconvulsive therapy. You're zapping my brain because you want to get my money. Now, that's not terribly bizarre, but in schizophrenia, delusions tend to be a bit more bizarre, such as, oh, the aliens are coming down, or the satellite is beaming information to my brain, or people want me to go into the hospital because they're going to put me in that MRI, and it's really going to take my soul. So again, delusions are seen in both mania, severe depression, and in schizophrenia, but in schizophrenia, these delusions are a bit more prominent and throughout the illness, whereas delusions typically in bipolar disorder or mania or severe depression with psychotic features tend to be at the most severe portion of the course of that illness. Now, schizophrenia also has hallucinations, usually auditory, but they also can be visual. Usually patients will say, oh, I'm hearing a voice, and the voice is telling me that I'm in trouble, or that I have to do things like hurt people or hurt myself. In bipolar disorder, people can also have hallucinations, but they're usually not very typical. Same thing goes with major depression with psychotic features. You can hear voices that really sound like more of your own, telling you that you're worthless and things of that nature. But again, it's at the more severe portions of the illness, whereas in schizophrenia, hallucinations tend to be more persistent throughout the course of the illness. Schizophrenia also has disorganized thinking. Sometimes patients with schizophrenia, when they try to talk to you, don't make sense. They tend to say things that perhaps kind of run from one topic to the next. This is what we call loose associations. Oftentimes you'll find yourself in talking to the patient like, whoa, I asked them where they lived, and next thing they know, they're telling me about the fact that the aliens have landed, and then they say something about totally unrelated. That's really how their brain is structured. In mania, as I mentioned earlier, somebody who has a manic episode they tend to talk fast. They have a hard time interrupting them, and they kind of go from topic to topic. Um, I guess the closest, perhaps, a person who does not have bipolar disorder would be if somebody who has had way too much caffeine and they're kind of chatty and they talk about one topic and the next. But one of the key differences is in what's called flight of ideas is you can follow why they went from one topic to the next topic. Whereas in schizophrenia with loose associations, you're like, whoa, I'm lost. Why do they go from this one to that one? I'm not. It doesn't make any sense to me. So that's the difference between uh, loose associations in schizophrenia and flight of ideas or pressured speech at times in mania. Now, the other thing too is that in bipolar disorder, people have a hyperactivity. They can really be intense and wanting to like draw these things or do things. Whereas in schizophrenia, although they can have abnormal behavior, it's more disorganized. Patients with schizophrenia have trouble taking care of themselves. They have what they call negative symptoms. They have diminished emotional expression, as well as they really don't have much desire to do things. And so, for example, what does that mean? This sort of avolition, they typically can have what's called catatonia, where they sort of stand in place and they seem to be distracted and bothered. You may hear the term, oh, they are responding to internal stimuli, which means that they're acting as if something's going on in their head and they're paying attention to that, and therefore they're paying attention to the person in front of them. People with schizophrenia tend to not pick up on social cues or what's going on around them. Now, one of the challenges is that somebody who's very depressed and profoundly depressed may appear as if that they might have schizophrenia or be psychotic because they just don't have the desire to do things. They don't want to wash. They don't want to, get up out of bed. But the difference between, say, schizophrenia and depression is that in schizophrenia, there's usually things that are quite bizarre and strange, whereas in depression, it's really just a lack of energy, a lack of desire for effort. In schizophrenia, it's because, well, they've kind of lost and understand that social cue. People depressed will tell you, I just don't have the energy, I don't feel like it, whereas people with schizophrenia go, I can't explain why, but I just, don't want to wash, or, I don't care to brush my teeth that often because it just doesn't, I have no awareness of that. So basically, there's lots of overlap, but just to recap, bipolar disorder really is typically has mania, can have depression, but not necessarily. And then in schizophrenia, the prominent feature is delusions, as well as hallucinations throughout the course of the illness. So you might say, well then, Dr. Lowe, what is schizoaffective disorder? Schizoaffective disorder technically means that you have schizophrenia, but you also have very prominent mood symptoms, meaning you can have what's called schizophrenia or schizoaffective disorder bipolar type, which means that you have symptoms of mania, or you could have schizoaffective disorder depressive type, which is that you have schizophrenia along with pretty significant depression. So it's really clear that schizophrenia and schizoaffective disorder are really in the realm of what we call psychotic disorders in comparison to bipolar disorder and major depression, which are both considered mood disorders. And as I said earlier, sometimes it's really challenging to make the diagnosis, especially in one visit. And so that's why perhaps one psychiatrist might say, oh, this looks like bipolar disorder, manic with psychotic features. And someone else might say, oh, I think the patient has schizoaffective disorder, bipolar type. It's not like one psychiatrist is right and one psychiatrist is wrong. Sometimes when in the course of the illness, one has to sort of see these trends over time, and therefore the picture becomes much more clear. Now, I guess this helps us lead into another topic, which is prevalence. So one of the questions was, what's the prevalence of these illnesses? Well, in general, in men versus women, it's pretty close. Some studies show that the prevalence in men to women is almost to 1 to 1. In fact, it's a little slightly a tick higher in men, like 1.1 to 1. So pretty much almost 1 to 1, pretty similar. The 12-month prevalence in the United States of bipolar disorder is actually 0.6%. Now, here's the thing. You might think 0.6% is kind of a low number. But you think about how many people live in the United States. Well, I think it said in the census, we have over 392 million people, or 328 million people in the United States in 2019. Well, 0.6% of that is over almost 2 million people. That's a lot of people living with bipolar disorder. And so that's very, very much a lot of people out there. Now, the other thing to keep in mind is that, as I said earlier, bipolar disorder can be diagnosed in children, but it's difficult because it often looks like possibly ADHD because those symptoms overlap quite a bit. Now, the other thing I want to say is that patients with bipolar disorder oftentimes struggle. So there were a lot of questions about treatment. So how does one treat bipolar disorder? When it comes to medications, one of the things that patients are often given are what's called mood stabilizers. These are medicines that basically do exactly as it sounds. They try to stabilize the mood by not allowing the patient to enter into a severe depression, but more importantly, not to have what's called a manic episode, where they're basically perhaps possibly doing things that are impulsive and intense that could get them into trouble. I think when I was on faculty at UC Davis, I remember a patient who was brought in because they had rushed the state capitol steps to enter into the governor's office because he had such a great idea that he couldn't wait, and therefore he was very impulsive. And of course, the police basically stopped him and brought him into the psychiatric hospital for evaluation and treatment. Now, typical mood stabilizers you may have heard of are lithium, Depakote, which is generic name is divalproic sodium, Lamictal, which is the trade name, and the generic name of that is lamotrigine, as well as Tegretol or carbamazepine, which is the generic name, and less commonly, but oxcarbamazepine, which is a generic name for Trileptal. So one of the things you might notice when you look them up is these are considered mood stabilizers, but many of them, Depakote, Lamictal, and Trileptal, and Tegretol are actually anti-epileptic medications, which means that they're used to treat seizures. Lithium is not used to treat seizures. So why is that? Well, it's partly because studies have shown these work, but one of the things that are people think why bipolar disorder happens is what's called the Kindling Hypothesis. What that means is that it's like the brain, if you think about it, has all these neurons that are constantly excited and basically are trying to connect to each other. And so one of the ways the brain is able to then not allow these things to spontaneously happen is that it has this what's called a negative tone, or ions that keep these neurons from firing and sending signals to each other. But in the Kindling Hypothesis, it's sort of like a spark. If there's a random spark and another random spark that are close to each other in proximity or in time, they might be enough to come together and basically spark a fire in the brain or some other signal that makes something happen. And so it's sort of, in essence, that majority of medications used to treat seizures keep down these sparks so that way the brain doesn't fire off a signal throughout the course of the sort of neurotransmitters. That's sort of a generic and oversimplified explanation. The reality is we really don't know that much detail. but in general, mood stabilizers help. Now, are they 100%? No, but in essence, one of the reasons why you really want to treat a manic episode is that if you don't treat it, patients do to come to some bodily harm or some occupational harm. They lose their jobs, or they have trouble interacting with their friends and family. The other thing I should mention is that in the course of illness, if you have a manic episode, then it actually makes it much more easy for you to have another one later. Which is to say that one of the challenges in bipolar disorder is that patients really like their mania. It feels great to have this excessive energy. They tend to be really, really creative, and they can also be funny. And so they kind of love this sort of attention. If you think about it, some people who have bipolar disorder actually, put it to their benefit, if you will. There are, for example, well-known actors such as Robin Williams, who have bipolar disorder, as well as singers such as, I think, Mariah Carey was diagnosed with bipolar disorder. So, and there's a whole host of other people as well. So, mania is challenging because people really enjoy it, and therefore they really don't like taking mood stabilizing medications because, well, that sort of dampens the euphoria and energy they have with mania. And, medications have significant side effects, which are not to be taken lightly, but hopefully the patient understands in the assessment of risks and benefits that it's good to take these medications to prevent problems, and hopefully the side effects are minimal and mostly like a little bit of stomach upset, or perhaps a little bit of weight gain, but in the general picture, it's really a trade-off for one's stability. Now, one of the challenges is that oftentimes patients who are manic are also taking what's called second-generation antipsychotics. These are medications such as Abilify or aripiprazole, Zyprexa, a generic name is olanzapine, or Seroquel, which generic name is quetiapine. Second-generation antipsychotics are really used to treat schizophrenia, but some studies have shown they're very efficacious in the treatment of mania as well. So one of the confounding things is that second-generation antipsychotics can be used as an adjunct, which means that the psychiatrist is prescribing them with the primary mood stabilizer, such as lithium or Depakote or Lamictal, in order to get the mania under control quickly. And therefore, in an acute manic episode, patients are both taking a mood stabilizer and a second-generation antipsychotic. However, for some patients, perhaps those that really don't find any mood stabilizers to be tolerable, they could be in what's called maintenance treatment or management of their mania using just only a second-generation antipsychotic. So when it comes to hearing about what medications the patient is taking for bipolar disorder, it can be confusing because mood stabilizers are used to treat mania, but also second-generation antipsychotics are used to treat mania. And then sometimes in schizophrenia, you'll see, and not schizoaffective disorder, you'll see patients on second-generation antipsychotics, and just to get things a bit more stable because they get agitated, they're on Depakote as well. So I guess the way to look at it is just because a patient is taking both a second-generation antipsychotic and a mood stabilizer doesn't mean that it explains whether they have bipolar disorder or schizophrenia or schizoaffective disorder. So it is a bit confusing. In psychiatry, we have a number of tools, if you will, in our toolbox to try to get patients stable, but the reality is we tend to use things just because we really want to get that stability for the patient. Now, as mentioned earlier, bipolar disorder can have depression, and while there are medications such as a combination of fluoxetine, commonly trade name is Prozac, as well as olanzapine or Zyprexa that can be used to treat bipolar depression, medications such as quetiapine or Seroquel, as well as lorazepam, Latuda, which are antipsychotics, can also be used to treat bipolar depression. And you have to remember that when it says that it can be used or they have an indication, it's that studies have shown these are beneficial in basically marketing studies that are submitted to the FDA. So therefore, when it comes to advertising these medications, the manufacturer can say, oh, used to treat bipolar depression, or used to treat acute mania, or used to treat maintenance in bipolar disorder. Now, why do they want these things? It's because if you have an indication, it's one you can market it for, but also it usually extends patent life, and therefore the manufacturer is the sole company that can make that drug, and therefore, have some profits. So in essence, after the patent runs out, then generic drug makers can make the medications, which make them basically much more affordable. So one of the questions that came up was, in the course of illness, after years of treatment, is it possible to stop medications and therefore still be functional? And the answer is yes, but one, you put yourself at risk for having a manic episode, and you don't know if necessarily that the manic episode is going to cause you harm in some way. Meaning that in the case of the other patient, running up the Capitol steps, or perhaps buying too much and buying that car and other watches that are very expensive that you really can't afford. And so, in my opinion, usually we don't recommend that patients taking mood stabilizers get off of them unless they typically have a really bad side effect that's of concern, and therefore something has to be switched to different medications. Now, in the treatment of adults, whether young adults or older adults, are there any really differences in terms of the medications used? Well, the answer is no. The one caveat is that as people get older, their liver doesn't work as well, their kidney doesn't work as well, and so therefore the psychiatrist really needs to monitor these medications and side effects and consider that they might actually lower them, not because the patient doesn't need them, but because since our body is not processing the medications as quickly, it actually is better for the patient to be on slightly lower doses of the medication. So that's really kind of the main difference between young and older adults when it comes to treatments with mood stabilizers and second-generation antipsychotics. Now, if somebody has depression, yes, you can treat them with an antidepressant such as you heard earlier, Prozac or Paxil, paroxetine. But one of the challenges of treating somebody with bipolar disorder who has depression is that medications such as antidepressants can do what they call flip a patient into mania. So therefore, it's really not good practice in the treatment of bipolar depression to give strictly a antidepressant medication without a mood stabilizer to have sort of a protective wrapper, if you will, to prevent to treat a depressive episode so that it doesn't get too far down, as well as to prevent having a manic episode where somebody goes into mania. And so these are key things to keep in mind. Now, I forgot to mention earlier that there is something called substance-induced mania or substance-induced bipolar disorder. And so what that really is that a patient has used, say, an antidepressant or they've used drugs such as amphetamines or cocaine, and therefore they have what looks to be a manic episode, and therefore it's called substance-induced bipolar disorder or mania. One of the key differences is that though when the effects of the drugs, or both illicit and prescribed, are removed, then the behavior or the episode of mania settles down on its own. In bipolar disorder, once the drugs or agents leave the body, if you will, which takes about 4 days, then the manic-like behavior should subside. And so that's how you can tell whether it's truly substance-induced mania versus, oh, this is just mania, but it was sort of inflamed or exacerbated by the substance. So one of the challenges with lithium is that it has long-term consequences. People complain of sort of dry mouth. It can be toxic over time to the thyroid or to the kidneys, and therefore that's why blood monitoring has to be on average every 6 months, although perhaps in more concerning times every 4 months. And sometimes patients who are trying to get pregnant, especially women taking lithium, have to be careful because there is a significant side effect, not that common, called tetralogy of Fallot, where it affects the development of the fetus's heart. Now, one has to weigh the risks and benefits in a pregnant patient about taking mood stabilizers, because overall, while there are risks of taking these medications, especially in the first trimester in terms of fetal development, a manic episode is not good either, and therefore having a good conversation with the psychiatrist as to the risk benefits of medications during pregnancy is very important. Now, how does one entice or get a patient with bipolar disorder in order to keep taking their medications? Well, I think education is really important. Education is that prevention of mania is just like preventing having bad consequences of diabetes. The better you get it under control, likelihood of you having a manic episode or severe depressive episode is less, and it's better overall for your health. So it's really important to take these medications. Now, it does come to mind that one could theoretically not just take the medication all the time, but only when you have a severe manic episode or a severe depressive episode do you take the medications. One of the problems with this is that if your depression gets very severe or you have mania and gets pretty bad, well, you can't prevent the consequences of them. And so to get you stable quickly may take time, and therefore it's kind of like saying, oh, well, if we only had applied water to the fire earlier, then the house wouldn't have burned down. So therefore, psychiatrists tend to say, well, we would rather you take the medication so that way you can prevent mania versus trying to give you all this medication at the same time to get it quickly dampened down. The other thing to mention too is, as I said earlier, that if you have a manic episode and it's not treated, then the next one can come a little bit faster and also be harder to manage, and therefore it's ideal to try to get these manic episodes secured and treated as quickly as possible. Now, is medication the only way to treat bipolar disorder? No. There are a lot of other adjunctive treatments. So sometimes in severe bipolar disorder, especially depression, but also mania, electroconvulsive therapy can be used, ECT, to treat that, although typically it's only used to treat severe depression. Now, can patients benefit from therapy? Absolutely. Therapy can definitely help depress mood, and therapy can actually help people somewhat in mania, more like education of their illness and the consequences of these things. But therapy alone is not going to prevent somebody from entering into a manic episode. But it's very important to consider therapy as their treatment. One of the questions is, what is the disease course of bipolar disorder? Are periods of mania and depression equally experienced with bipolar disorder? The answer is no. People can actually have bipolar disorder with only manic episodes and never experience a severe depression. However, many people with bipolar disorder experience both the highs and lows. So they'll have a manic episode, followed with a period of stability, and then experience a severe depression. So therefore, they have so-called the bipoles, if you will, of mania and depression. Most cycles happen once per year, although some patients have them every 2 years. Everybody's very different, so it's hard to say what the exact course will be. We do know that patients with bipolar disorder
oftentimes will relapse because they stop taking their medications because they enjoy the euphoria of mania, and therefore it's hard to continue to take medications that sort of called dampen your spirit. I can understand that. But the reality is, the benefit is if you take medications, both to treat a depressive episode as well as prevent manic episodes, then typically patients then can actually stay functioning at work with a good quality of life at home, because that's really the goal we psychiatrists have for the patient, which is to have the best quality of life possible. I would imagine that includes staying out of the hospital. Anyway, as a family, there's tremendous impact on you. And so one of the questions is that, can you forgive the person and the disorder for the trauma they've caused you? I think that's a very individual decision as to what you do and how comfortable you are. And as a psychiatrist and somebody who is taking care of the patient, I really do support whatever stance you need to take. If you have the energy and the time as well as finances to support your loved one who has a chronic illness, then by all means, if you can do it, you should. But at the same time, if you've been burned one too many times for promises that says, oh yeah, I'll take my medicines, or no, I will go to the doctor, oh yeah, I'm going to stop using drugs, don't worry about it, and yet you find yourself disappointed, then it's totally fair and appropriate for you to say, no, I've had enough, I can't do this again. So that is really up to you how you want to handle it. There's no right answer. It's what's best for you. Now, what strategies can family members employ to help somebody with bipolar disorder? I think ultimately the goal is to be firm and consistent in terms of your support for that person. Now, one of the things I do note is that if a patient is in and out of the hospital oftentimes or goes to different psychiatrists, if you have some records that you keep, so that way for example, when they were first hospitalized, how many hospitalizations they have, what medications they've tried, and especially if you have the contact information for the last psychiatrist, whether on outpatient or inpatient, then that's very helpful to the next doctor in line in our system of care. It's very helpful because, as I sort of said earlier, the picture of bipolar disorder is a challenging one in terms of it's only a snapshot when we see the patient at that one time period. We don't know what the patient was like 6 months ago. So we can imagine if somebody is coming off a manic episode, they might start looking more normal and not manic. By the way, if I had seen that patient 2 weeks ago, I would totally see a different picture. I can tell you an example at one time was a patient actually that I had seen at one hospital I worked at actually recorded herself and posted it on YouTube, so I checked that out and I was able to see her quite manic in that YouTube video. So the diagnosis was much more clearer. Overall though, why is this detailed information helpful? One of the things it can do is it helps the provider decide what the next steps are in terms of managing their care when somebody has severe depression or mania in the hospital setting and appears to be getting stable. If, for example, your records tell us that they've had recent hospitalizations in the last month or two, and therefore the doctor may be more conservative then and say, okay, well, person looks good, but given that they've had several hospitalizations, I'm not sure why, it's because they stopped their medications or maybe it wasn't stable enough, they might keep them in the hospital a bit longer. So this reminds me of the next question and concern. What should I do when I hear from the patient's right advocate or the hospital about there's a hearing, typically on what's called the 5250 or 5270? These are welfare and institution codes as part of the Lanham-Petra Short Act here in the state of California. The LPS Act allows for patients who are a danger to others, danger to themselves, or what's gravely disabled, which is really the inability to provide for food, shelter, and clothing, to be detained and treated in a psychiatric hospital. So if you hear from a patient's right advocate that says, hey, this person lives with you, right? Can they come back home to you? Well, you need to answer truthfully. What I mean by that is, if the answer is yes, but you really don't feel that the person is ready, then you must state so. You must say, hey, welcome that person back, but on the condition that the doctors think they're ready and stable to return home. I'm not prepared to take them now. So this sort of sends a message to the patient that, hey, you're not quite ready yet, but no, at the same time, I do still love you and will take care of you, but I just think you're not ready. You might think that, oh, this might be upsetting and therefore you shouldn't say no to the person, but patients really need to hear that there are limits, that there really isn't this sort of unconditional love and support for them, because there are consequences to their actions, especially if they're med non-compliant. Now, the other thing to consider too is that, and I've done this before, if the patient really thinks that they're ready to go home and family members agree and want the person home, then as the psychiatrist, I'll go with that and I'll discharge them. I may disagree with it because in my experience, this may seem too early, but to be honest, I don't know the patient that well. You've lived with them longer, and so if you feel comfortable, you should say that, if that's really what you want to do. Now, one thing to consider is that if somebody's in and out of the hospital multiple times, the psychiatrist might consider what's called an LPS conservatorship. What this means is that somebody then basically has the right to make decisions when it regards to psychiatric care and also living situations for that person. In essence, they've lost their rights for a year to make informed decisions about their psychiatric condition and treatment. This means that the conservator, whether it's a public guardian or a private one, can decide and consent for hospitalizations, medication consents, finances to, oh yes, I will give you X amount of dollars out of your Social Security income to spend, or no, you're not going to get any money because I need to pay for the board and care. Now, an LPS conservatorship is for a year only. It can be renewed in the court, especially if it took a long time to get there and the person doesn't demonstrate any insight. And therefore, it's not forever. Patients oftentimes do get off a conservatorship for a year and then have a chance to redeem themselves and show that they really are going to stay on medication and stay out of the hospital. And, for some patients, that's really all it took to really get them better. But others, unfortunately, and this chronic illness of bipolar disorder, they oftentimes relapse and therefore end up needing to be in the hospital again and ultimately possibly back on conservatorship. So it's fair, as you heard, the impact on family is tremendous, and there's no right or wrong answer as to what to do for that loved one. I think it's fair that you are supportive because you want to be, and that's in your nature. It's also fair if you've been sort of burned once too many times of promises to stay on medications or promises to stop using drugs as part of their illness, and therefore you just feel like you can't go there anymore because it's really not in your heart to be disappointed or to be hurt emotionally from this. So these are challenging situations really on a case-by-case basis. And please, you must do what's best for you. That's really ultimately what needs to happen, because if you sacrifice yourself too much and therefore you're not available when the person really needs it, then, I think you have to prevent that kind of scenario from happening. One thing to mention is there is a risk of suicide. Suicide risks are more obviously when somebody is severely depressed, because no one really enjoys a depressed mood, lack of energy, feeling hopeless, feeling like the world is over and going to end. But patients with bipolar disorder, typically who are manic, aren't often at all suicidal. In fact, they're full of that joy in life and therefore are quite euphoric. The hazard comes in bipolar disorder with mania, that patients sometimes will take on things that they really shouldn't. For example, they might go to a rally and start, confronting police as part of that heightened energy and a sense of doing what's right, for the movement, and yet they get themselves into harm's way. So there is that risk in bipolar disorder for things like that to happen. Now, we should talk a little bit about and summarize what we reviewed. diagnosis of bipolar disorder is that it requires a diagnostic interview as well as information taken from you, if you have it, about where the person's been hospitalized before, what diagnosis they've had, what medications they've taken, if they have any bad reactions to medications, as well as the name of the latest psychiatrist that they saw. That information is very helpful, especially if in our system of care, patients have bounced around from place to place, because not all hospitals are connected via a same electronic health record, and therefore information is not always well exchanged. And sometimes we as psychiatrists really depend on that information to make the best decision for your loved one. For example, if I've heard that the person has been in the hospital 3 times in the last 2 months, I might keep them a little bit longer to make sure they truly get stable before I discharge them. So whatever information you have can be relevant and important in the care of your loved one. Now, one of the challenges in diagnosis is that there are snapshots over time. So oftentimes patients look depressed one month and say the next month they may look more manic. And so depending on when I get involved in their care as a psychiatrist, I get a sort of sense of, oh no, this is just depression. Oh yes, this is clearly mania. So while we try to get history from the patient, sometimes things can be convoluted, especially when substance abuse is involved. I can tell you a great example I had of a young woman who I thought had schizoaffective disorder, because she would tell me that she heard this voice telling her to go out and do things. And so I thought, oh, that sounds like psychosis, that sounds like schizophrenia. And so it wasn't until after she had been treated from using amphetamines and was actually clean for about a year that the picture started looking a little different. Her affect, which is the observable state of her mood, seemed to be more clear. She didn't have any classic negative symptoms that normally I see in schizophrenia or schizoaffective disorder. And so then I began to realize something looked different about her, especially when she reported to me having decreased need for sleep, increased energy, more impulsive behavior and risk-taking things. And so basically she described mania. And fortunately she described it early enough they were able to put her on the right mood stabilizing medications to prevent hospitalization again. So sometimes substance abuse and use of amphetamines, cocaine, and other stimulants can really muddy the picture. Now, yes, caffeine is stimulating as well, and can that cause a manic episode? Not typically, but potentially in a person who is very sensitive, yes, especially if it keeps you from sleeping at night and kind of stimulates possibly a manic episode. So one of the things we talked about again is what's the difference between schizophrenia, schizoaffective disorder, and bipolar disorder. Remember that depression and bipolar disorder are what's called mood disorders. They're disorders of mood. And basically once you're stable, you return to what's considered a baseline where no one can tell that you've had necessarily a mental illness. Schizophrenia and schizoaffective disorder are a little bit different. Unless a person is extremely high functioning, usually there are some residual symptoms of psychosis. Either they continue to have hallucinations, or they have negative symptoms, kind of a blunt affect or lack of concern for others, or they still hear things at baseline. And remember, in schizoaffective disorder, it means you have schizophrenia, but at the same time you've experienced either a manic episode or a depressive episode. And so therefore, try to be clear on what the diagnosis is, because it's helpful to the psychiatrist treating your loved one to figure out what the right strategy to take. Now, to be fair, as you've heard earlier in our discussion, patients with bipolar disorder are both treated with second-generation antipsychotics as well as mood stabilizers. And so on one hand, I suppose you could sort of argue it really doesn't make much of a difference, but I think given that many of our famous singers and people in the movie industry have bipolar disorder, I would say that to accurately diagnose that somebody has bipolar disorder versus schizoaffective disorder, the stigma of having a chronic illness like schizophrenia is a bit higher. And so perhaps you do really want that diagnostic clarity. As we've talked about, medications really need to be taken for life, because this way your loved one has the best opportunity to have a normal quality of life where they can have a job, live with their family, and really enjoy everything they should be able to enjoy in managing their illness. So I really appreciate your attention on all these matters. And I think that, just like all mental conditions, bipolar disorder is oftentimes misunderstood, but also it's really a challenge at times to make an accurate diagnosis. And so you, as a family member, have a very significant role in how well their care goes. That includes, as I said, keeping records to help the doctor know what's happened in the past, what's worked well, and what has not worked well for that person, as well as the support you provide in terms of a place to stay or finances. Whatever's comfortable for you and what seems best for you is really the answer, because everybody's different, and everybody's experience with bipolar disorder, unfortunately, is different as well. So I thank you for your attention, and please enjoy the rest of the NAMI conference.
Thank you all for joining us for the conference. I'm sorry for any audio issues, but we will be cleaning up that video and posting it later. We did record it. Thank you so much, Dr. Lowe, for answering all those questions in the chat. If you guys have any additional questions for Dr. Lowe, you can message him on the Whova app, and he can get back to you and also give you any other contact information that he would like for you to get to him on. Anything you'd like to add, Dr. Lowe?
No, I just want to thank everyone for attending. I know the audio was not the greatest, but I think the content and the issues are real, and therefore I'm happy to answer anything on the Whova app, or you can find me via email at johnlowe@uci.edu. So I welcome your further questions. Thank you so much for attending.
Thank you, everybody, and we hope that you enjoy the rest of the conference. See you later. Bye.
Bye.